Hello. It's an honor to be with you today, and I'm excited to talk about one of my favorite things, newborn screening. Before I begin, here are my disclosures. My name is Lesa Brackbill, and I live in Hershey, Pennsylvania, but I'm originally from Northern California. I've been married to my husband, Brennan, since 2010, and we have three children, Victoria, Isaiah, and Caleb. I have a degree in political science, and I am pursuing a master's in strategic communication, which I will finish next year, and I have lobbying experience. I am the author of Even So Joy. I've been an advocate for newborn screening for KRABBE disease since 2015, and I helped start the Leukodystrophy Newborn Screening Action Network, or LDNBS, in 2020, where I currently serve as the Director of Advocacy. Before I begin, I want to introduce you to my daughter, Victoria, or Tori, because the work I do today is because of her, and I do it to create a legacy for her. I also want to highlight the work I did in Pennsylvania before co-founding LDNBS. It's a common tale in this community. Our children are born healthy and strong, and we are blindsided later by a crushing reality called leukodystrophy. That's certainly our story. At 5 months old, Tori became a completely different baby, as though someone had flipped a light switch. At 6.5 months old, Tori was diagnosed with KRABBE disease, and she died 14 months later at 20 months of age. My advocacy began in that small room on diagnosis day, though I didn't get to actively pursue it outside the home until after she passed away because I was her primary caregiver. At that moment, I realized that this was always supposed to be my story as much as I wanted to resist it. My education, experience, and skill set were perfectly suited to fight for change, so I learned to embrace it. 10 days before Tori died, we advocated together at the Pennsylvania State Capitol, having no idea that she would soon leave us. 3 weeks after she died, I attended my first meeting of the Pennsylvania Newborn Screening Advisory Board and testified that day about the fact that newborn screening for KRABBE disease was necessary. That day began my learning about newborn screening, and I have continued to learn as much as I can from every possible angle so that I can help others identify and resolve the underlying issues in each state that prevent them from having a robust, expanded newborn screening system. What I learned at those meetings turned into 3 pieces of legislation over a 5-year period, 2 of which failed due to partisan politics, with eventual success in November of 2020. We had just introduced our third bill when COVID hit, and I was determined to get it to the finish line this time, despite all the odds against us. So, we held virtual stakeholder meetings to learn how the bill would impact others, and we made some changes that strengthened the bill. Had we not listened, we wouldn't have the program we have today. This picture is from our ceremonial signing with Governor Tom Wolf, who was the governor at the time that our legislation went into effect. And I was able to tell him that day that we had already found several babies with KRABBE disease. This was taken in September of 2022. I want to mention that my bills did not seek to add KRABBE disease by legislative mandate, but instead sought to fix the issues preventing it from being included. Sometimes that's what it takes. As you can see here, Pennsylvania certainly had some big problems to solve, but now our program is strong, flexible, and free to add conditions that the advisory board deems fit, regardless of RUSP status and without any involvement from the legislature. Because of my persistence with the advisory board, screening for KRABBE began in May of 2021, and 5 babies have been identified with KRABBE disease through newborn screening since then. If you're wondering, why did she tell us all of that? We don't live in Pennsylvania, and she fixed the problems there already. It's simply because I wanted to highlight some creative solutions that made newborn screening for KRABBE disease a reality in our state and could work in yours as well, and to earn your trust since you may not know who I am. Today, I will be covering the following with plenty of time for questions afterward. We're going to talk about the mission of LDNBS, what is newborn screening, the status of newborn screening for leukodystrophies, the impact that the recent ACH-D&C decision may have on advocacy efforts, how LDNBS can help make newborn screening for leukodystrophies a reality in your state, and what resources we have created to help educate and equip advocates. The Leukodystrophy Newborn Screening Action Network is dedicated to advancing newborn screening supporting newly diagnosed families, and encouraging collaboration, coordinating efforts, and removing barriers. We started this in April of 2020 with these three main objectives. We seek to equip advocates who want to see their condition added to their state's newborn screening panel and offer numerous tools and resources to help them succeed. The vision is that we can help each other across conditions to work on seeing all states screen for as many leukodystrophies as possible. Currently, our focus is on the leukodystrophies with newborn screening tests either fully implemented or in pilot status, and we can't wait to see that list grow. Before we get into what newborn screening is, I thought we should hear what the founder of newborn screening said. He said, "No child should die or suffer disabilities if a simple blood spot can prevent it." What is newborn screening? Let's talk about what it is because I don't want to assume that everyone listening is aware. Newborn screening began 60 years ago with a metabolic condition known as PKU. In the years since, dozens of conditions have been added to state panels and to the Federal Recommended Uniform Screening Panel, or RUSP. There's a lot of acronyms in this world. It's important to know that newborn screening is not just a test, it's a system. It starts with scientists and chemists like Dr. Gelb, who develop the actual assay that can detect disorders, lab technicians who run the tests, state newborn screening programs who manage the entire system, geneticists, genetic counselors, clinicians, specialists who deliver the news, treat the patients, and others. It's also not just one test, it's three. It involves a dried blood spot test, a pulse oximeter screening, and a hearing test. The dried blood spot aspect of newborn screening, which is the relevant test for leukodystrophies, takes place 24 to 48 hours after birth, and the timing of that is extremely important because if the test is performed earlier or later than that time period, the results can be inaccurate. The baby's heel is pricked and blood is put onto filter paper as shown in this picture, which is from one of my twins. I actually insisted that it be done in the room so that I could see it and photograph it. The blood spots on this filter paper are then sent to the lab for analysis. What are they looking for in the lab? Using Krabbe disease as an example, the test looks for low GALC enzyme levels, and if those are detected, they do a second-tier test for high cytosine, which is a toxin, levels. This toxin is what destroys the myelin in the body and leads to the damage of the white matter. The MLD example is that they're looking for elevated sulfatide levels and then ARSA activity and then related gene mutations in both examples. It's also important to note, and this is going to be a very common theme, that each state operates its newborn screening system very differently. Some states use their own lab, but several states use another state's lab or PerkinElmer Genetics lab to process their newborn screening. Many states screen for different numbers of conditions, though the disparity is not as bad as it looks, and we will talk about that later. Many states now have what we call RUSP alignment laws, which help conditions be added more quickly, but 39 states don't. And of course, money. Each state funds their newborn screening program a little differently. One way conditions are added in 48 states are through newborn screening advisory boards. You might be surprised to learn that you don't actually have to pass a law to add a condition in most states, and we typically steer our advocates away from the legislative route. So the newborn screening advisory boards are typically composed of geneticists, pediatricians, specialists, and parents. Of course, the authority differs from state to state. Some advisory boards have direct power to add conditions. Others recommend to their state's Secretary of Health, and the Secretary of Health will make the ultimate decision. By now, you've already heard the acronym RUSP, so I wanted to take a moment to talk about what the RUSP is and what it isn't. In 2002, some states were screening for as many as 50 conditions, while others were screening for only 4. In 2005, the American College of Medical Genetics and Genomics was tasked with developing newborn screening guidelines, and ultimately they put 29 core conditions on the original recommended panel that preceded the RUSP. That list was published in 2005, and in 2010, it officially became known as the RUSP. It became the nation's minimum newborn screening standard. Its mission to increase uniformity in screening between states has largely been successful, but there is still room for improvement. Note that it is recommended, not required. Another acronym you will hear in relation to newborn screening and the RUSP is the ACHDNC, which stands for the Advisory Committee on Heritable Disorders in Newborns and Children. You probably see why we use an acronym. It was formed in 2003 as part of this same uniformity mission. It meets 4 times a year. They review evidence from nomination packages that are submitted from advocacy groups. They recommend that conditions be added, or they vote that they shouldn't be added. But ultimately, the Secretary of Health makes those decisions. I also wanted to point out that since 2015, only 5 conditions have been added to the RUSP. Additionally, it takes up to a decade for every state to implement screening for new RUSP conditions. As an example, X-linked adrenal leukodystrophy was added to the RUSP in 2016, and only 36 states plus DC are currently screening for it 7 years later. Because of this, the Every Life Foundation began introducing RUSP alignment legislation to not only require that states add RUSP conditions within a 2 to 3 year time frame, depending on the state, but to also equip those state programs with the funding required to make that a reality. So far, 11 states have RUSP alignment laws in place, but not all of them are well written, and some are overly restrictive, like California. Wisconsin is also currently considering this initiative. The RUSP nomination process is a lengthy and laborious one, and the Hunter's Hope Foundation took the lead on this twice for KRABBE disease. Our, quote, day in court, so to speak, was on February 9th, 2023, and we were shocked at the outcome. The ACHDNC voted 7-7 and interpreted that tie as a no. Evidence was ignored, clear bias was shown, and this could all be a presentation by itself, so I won't go into all the details. However, the advocacy community, scientists, and clinicians decided that we weren't going to allow this to be the final decision. After all, it's a recommendation. The Secretary of Health makes the ultimate decision. So we decided to try. We tried to appeal. We sent 2 separate letters, and by letters I mean 20-page documents. One was sent from the doctors who are experts in KRABBE, who nominated it to the RUSP. The other one came from the advocacy community, and we refuted the false claims. We are still awaiting a decision from the secretary, but we feel slightly hopeful after the May ACHDNC meeting because the committee seems willing to make some changes that will not only be beneficial to the KRABBE nomination, but others that follow. This is important because MLD and others are planning to submit to the RUSP in the near future, and we want to improve the process before then. The ethics behind adding conditions to newborn screening panels are extensive, so I'm only going to highlight the criteria that have been used for decades. In recent years, they have been changed slightly, but they still maintain this original Wilson and Youngner criteria. So, what does it take for a condition to be considered worthy of addition to a newborn screening panel? To summarize this list, most newborn screening programs want to know if there's an accurate test, if there's an approved or effective treatment, and if the treatment can be done in their state. Why does this matter? Later on, we will go through the LDNBS 3 pillars of newborn screening advocacy, and this will be helpful for context as we talk about knowing our disease. I mentioned earlier that the disparity between states when it comes to the number of conditions on their newborn screening panel isn't as extreme as it seems, and I wanted to mention that here. If you look at a list of the states and the number of conditions, it looks like there are drastic differences ranging from 34 to 80 conditions. But here's what you need to know. There are core conditions, which are conditions that states are intentionally looking for when they analyze the blood spots. There are secondary conditions, which are conditions that can almost accidentally be picked up when they're looking for the core conditions. Multiple sulfatase deficiency is an example of a secondary condition because it can be picked up if the states are looking for MLD or MPS II, as well as some other conditions. Some states only show the core conditions in their count, while others add everything they can, perhaps to look better than other states. I don't really know. There is a group working on standardizing how the conditions are counted, thanks to the Association of Public Health Laboratories, or APHL, and we may have a more consistent way of counting in the near future. Let's look at the status of newborn screening for leukodystrophies. As I mentioned before, despite being added to the RUSP 7 years ago, only 36 states plus DC are actively screening for X-linked adrenal leukodystrophy. Elisa Seeger and the ALD Alliance have done tremendous work to get it this far and continue to work on the federal level to end what they have deemed death by zip code. But it shouldn't take this long to see every state screen for a RUSP condition. There are currently 11 states screening for Krabbe disease, with South Carolina being the most recent addition in May of 2023. In total, 14 states have agreed to begin screening, but 3 have not implemented it yet. New Mexico and Louisiana both have laws in place, but have not implemented. And Minnesota's Newborn Screening Advisory Board just voted earlier this month to begin the process. MLD is currently part of the SCREENPLUS project in New York, and we will talk about that next. In addition, thanks to the efforts of the Evanosky family in honor of their 3 sons who all had MLD, Illinois passed a law to begin screening for MLD earlier this year, and it is estimated that they will begin screening sometime in 2024. There are also states that are looking into implementing pilot studies. PerkinElmer is preparing their lab-developed test, and there are several states or several countries in Europe and the Middle East that are also beginning their own pilots. In fact, in Germany, they have already identified. I forgot that I had a slide for the Europe one. So this shows the newborn screening studies that are currently happening. And in Germany, through their newborn screening pilot, they have already identified 3 children with MLD. It is an incredibly hopeful time for metachromatic leukodystrophy. CTX is also currently part of the SCREENPLUS project in New York, and they are waiting for a patient to be identified through newborn screening in order to validate the assay. CTX already has a treatment. GM1 is also currently part of the SCREENPLUS project in New York, and their goal is a little bit different. Their goal is to validate their newborn screening test so that when they have an approved treatment, which they believe will be in the next 5 years, they will be ready to go with newborn screening advocacy and a RUSP nomination. SCREENPLUS is a unique program happening in New York that currently includes 14 disorders, 3 of which are leukodystrophies and 10 of which are lysosomal storage disorders. SCREENPLUS is an opt-in, consented research program that is helping to provide much-needed data both on the newborn screening assays themselves, but also on the psychosocial impact of newborn screening. This innovative project is so necessary because in order to submit to the RUSP, you have to prove with data that the newborn screening test works and that a patient has successfully been treated as a result. Many states don't allow pilot studies or don't have the resources to run them. How are advocacy groups supposed to get this data? Projects like SCREENPLUS in New York and Early Check in North Carolina are paving the way for that data, and we hope to see more like them in the future. You may be wondering, why aren't states screening for my condition? Why can't they just screen for everything so that a parent knows that their child has that condition? It may surprise you that it's usually not because they don't want to or are against it. Usually. There are so many parts to the newborn screening system, and each state faces its own hurdles and barriers for expansion. Some of those hurdles are 12 states use another state's lab for their newborn screening, so they can't add a condition until that state adds it. A great example of this is Iowa. Iowa does the newborn screening for Alaska, North Dakota, and South Dakota. So advocating in those states that use Iowa is a little tricky because they don't get to control what Iowa screens for. Another example of this is New Mexico. They have had a law in place to screen for Krabbe for over a decade, but because they use Oregon's newborn screening lab, they can't implement it until Oregon does. There are certainly advantages to this method, but as you can see, there are also some challenges. The first challenge is, of course, that you have to wait for that state to add a condition before your state can. The advantage for states, though, is less funding required to add a condition because Montana, for instance, with using Wisconsin's lab, they don't have to add staff, buy equipment, anything like that to add a condition. Wisconsin does. You can see on this chart that some of the state labs are screening for more conditions than the states that use that state's lab. Let's look at the New England states as an example. Massachusetts does the screening for Maine, Vermont, New Hampshire, and Rhode Island. Massachusetts says that they screen for 66 conditions. The other states are seemingly lagging behind. Remember that it could just be a matter of how they count their conditions differently, but it could also mean that there are more conditions that they could easily add if they wanted to. For the states that use PerkinElmer for their newborn screening, the advantage for them is that PerkinElmer develops newborn screening assays and reagents to sell to state labs. They can screen for so many conditions. As an example, they are currently developing their MLD assay, and when that happens, we can approach the states that use PerkinElmer, as well as states with their own labs, and let them know that it's ready and available. We can also currently approach those states about screening for KRABBE and other lysosomal storage disorders because they already have the assays available to them for little to no extra cost. Pennsylvania is the only state on that list that is currently screening for KRABBE. As I mentioned earlier, several states have adopted RUSP alignment laws that require them to begin screening for conditions on the RUSP within 2 to 3 years of addition. These are great laws. However, some of the states that have adopted RUSP alignment laws have language in place that is interpreted to mean that they can only add RUSP conditions. California is an example of this. Their 2012 law inadvertently prevented innovation and advocacy efforts. Because of what we saw happen in California, when I was drafting the legislation in Pennsylvania with my senator, we added a line that gave direct authority to our newborn screening advisory board to be able to add non-RUSP conditions that they deemed ready. Conditions become more widely adopted when a few states are willing to take on the challenge and be first. That's where the assays are perfected and the data is generated. We have to ensure that anything that we attempt to do allows for that innovation. We also have to learn from other states and what they have done well and where they have missed the mark. Many states prefer to only add RUSP conditions because of the vetting process undertaken by the ACHDNC. It saves the states time, effort, and money to go by what the ACHDNC says instead of having to launch their own investigations. But usually it does come down to funding, which is why my work in Pennsylvania sought to take the legislature out of the equation. Did you know that insurance is federally required to pay for newborn screening? While this wouldn't work in every state, we shifted our funding structure from a budget line item to insurance, enabling us to add conditions as Pennsylvania sees fit, not what politicians want to pay for. Mass spectrometers, which are the machines that run newborn screening for leukodystrophies, can cost around $500,000 each. There are staff to pay, electricity bills. You get the idea. It costs a lot of money to run a newborn screening program. Additionally, the Newborn Screening Saves Lives Reauthorization Act at the federal level has not been renewed. One senator held it up last session. And that act provides funding opportunities for states to implement new conditions as well as many other critical things. These are only some of the major hurdles that states are facing. In addition, there have been a couple of lawsuits in recent years regarding the storage and usage of dried blood spots that could become potential hurdles in the future if the issues are not fully understood. There is also an increased and I believe misplaced distrust in the public health system as a result of the pandemic. And because newborn screening is part of the public health system, which requires trust to operate, there could be unintended consequences. I won't go deep into these lawsuits, but briefly, in Michigan, a group of parents who had signed the consent forms to have their child's blood spot stored and used for research, de-identified, which means no one knows whose blood it is, they successfully sued, stating that their constitutional rights had been infringed upon, and it is currently being appealed. In New Jersey, law enforcement actually used a dried blood spot to convict that child's father of a crime. What happened in New Jersey was absolutely wrong. That is not what dried blood spots are supposed to be used for. But as a consequence of these two bills, millions of dried blood spots have had to be destroyed, and that is detrimental to the newborn screening community and to the scientific community. So, with all of that, what can we be doing right now? This is certainly an interesting time for leukodystrophy newborn screening. And for most conditions, we're kind of in a time where we have to wait for one reason or another. But I believe that waiting is wise. For KRABBE, we are waiting on the ACH-DNC, and there's a risk that states will be hesitant to add KRABBE disease now because of the February decision. It's possible they simply heard it was a no vote and they won't look into what actually happened, though we hope that's not the case. For MLD, we are waiting for FDA approval of a gene therapy so that we can submit the RUSP nomination with an approved treatment. For CTX and GM1, we need SCREENPLUS to identify a patient to validate the assay. Waiting is difficult. I fully acknowledge that. But while we wait, there are things that you can be doing to become more educated about newborn screening itself, how to advocate effectively, and perhaps most importantly, we can all be building relationships with stakeholders. The three pillars of LDNBS's newborn screening advocacy philosophy are to know your disease, know your state, and know your story. First, it's important to know your disease. LDNBS works with any interested leukodystrophy or lysosomal storage disorder, and it's important to know that not all leukodystrophies have a newborn screening assay or test. Not all leukodystrophies have a treatment. The lack of those two things makes newborn screening impossible. So it's important to know as much as possible about the condition for which you were advocated before you start. Knowing everything you can about your condition's newborn screening assay and treatment will help you advocate effectively, and we can help with that. The next step is to know your state. Know how it operates, who the decision makers are, if they have a newborn screening advisory board, which if you live anywhere except for New York and California, they do. If they have a nomination form that your advocacy group can fill out, if there are other issues preventing the addition of your condition. There are so many possible underlying issues that we could solve. But I also want to acknowledge again that only 2 states require legislation to add conditions. Only 2. My experience has taught me that the best way truly is to go through the newborn screening advisory boards and state labs. Why? Because they are the medical experts. They understand the needs of their newborn screening program, and it's a lot easier in most cases because you leave politics out of it. I watched this play out in Pennsylvania as my nonpartisan newborn screening bill became partisan because of the party affiliation of the bill's sponsor. That's why I now believe that politicians should not dictate health policy. The medical community should. I'm going to show 2 state examples because they demonstrate some of the key points I mentioned. Let's start with my home state of California. On paper, California leads the nation in the number of conditions screened, which they say is 80. But remember what I said about that. They also unintentionally eliminated the ability for advocates to add conditions through their 2012 RUSP alignment legislation. The way that it is worded makes it so that only RUSP conditions are added to California's panel. This is why we were careful in Pennsylvania to add a sentence giving full authority to the Newborn Screening Advisory Board in addition to being aligned with the RUSP. California uses the ACH-DNC as its Newborn Screening Advisory Board, which I would have said wasn't a bad idea until February, when things did not go our way for KRABBE disease. Rhode Island is a great example of a state with RUSP alignment legislation that can't fully do what it wants because it relies on another state's lab. Even if they wanted to add KRABBE, MLD, or another condition today, until Massachusetts has the capability to do it, they cannot. Advocacy is therefore limited, though not entirely useless because the Rhode Island Advisory Board still has to decide to screen for any new conditions. The last pillar is knowing your story because that's the easiest part. You have lived this. Most of us could talk for hours about our child, our experience, and our trauma, because our child wasn't screened at birth. However, most decision makers do not have that kind of time. So you will need to develop a pitch, a shorter version that packs in all of the necessary information. You could also create a one-pager, as I will show later on. Learning about your disease and state helps you craft your pitch. As you're learning, you can look for known or potential obstacles to adding your condition. You can also consider what will speak their language. Sometimes it's comparing to other states, which is a tactic I used here in Pennsylvania. I would point out that because only 10 of our conditions were mandatory at the time, we were actually ranked second to last in the country. They did not like to hear that. Sometimes, usually, it is using data and statistics while also appealing to the ethical and moral aspects of screening for that condition. But it's almost always about saving money while you're saving lives. But it's about the money. I have ideas about how to incorporate these things, and I have examples from my own work if you're interested in the future. I do want to point out that offering a solution to the problem is great when possible, but just know that it's not your job to do that. Your job as a leukodystrophy advocate is simply to make the decision makers aware of the issue, tell them your story, and ask them to help. Don't take on the extra stress of trying to fix a broken system. Learn from those who already know and ask those who already know to help. While your story is incredibly impactful, it's hard to admit that sometimes our stories aren't enough by themselves. And that's why we ordered these pillars as we did. More than once when I have testified, much of the data that was given in opposition to screening for KRABBE wasn't accurate. Thankfully, I had my own published data to counter what they said. As much as we want our stories alone to be powerful enough to make our case, having data gives us credibility and helps us establish facts, not just opinions. I also love this quote, though, because I feel like it captures why it does take both. It takes facts and data, like knowing your disease, science, and statistics, but it also needs a human story to have the most impact. Coupled with your example of how newborn screening might have changed your life, this will influence decision makers to support you. In addition, I wanted to highlight these 5 things that I think are some of the most important things that you can be doing. The first is to always be kind. Being firm is okay, being blunt and bold is wonderful, but do it with kindness and respect. Remember that you want these decision makers on your team. You don't want to make enemies. Build relationships with anyone you can. State representatives, senators, their staff, the newborn screening director. In fact, really with the newborn screening director, because you can ask them what hurdles you would face in adding your condition. Meet your newborn screening advisory board, attend their meetings because they are open to the public. Even though we don't advise legislative mandate to add conditions, your elected officials can sometimes help you find the right people and put pressure where needed because they know which buttons to push. Find other rare disease groups in your state and learn from them. Find groups that have a common goal and build a coalition. Your state's Rare Disease Advisory Council, if you have one, would be a great place to start. You can create one-pagers or other resources so that you are ready to hand out information that will be memorable. Determine what has already been done in your state by other newborn screening conditions. How did they get it added? What lessons did they learn? What issues did they find or solve? And what's left to solve? Along with that, examine the playing field and try not to duplicate efforts when you could be multiplying them. That's one of the reasons LDNBS was started, to stop the duplication of efforts. We must be unified in our advocacy and work together no matter how challenging that is. I'm now going to share some examples of resources LDNBS has developed, and I will have this same QR code available at the end if you'd rather wait to scan it. Or just go to ldnbs.org and you can find our resources there. And if you have ideas for resources that would be useful, please let me know because we are always looking for new and fresh ideas. We're going to start with my beloved spreadsheet. This is my absolute favorite resource. I love spreadsheets. I have been developing this over the past 3 years and I continue to update it as new information is available. It contains information that was useful or that would have been useful during my own advocacy in Pennsylvania, and it helps me build the strategy for each state. I know it's small. You can visit ldnbs.org for a link, and it's under the resources tab. The other tabs that are on that spreadsheet are relevant for specific conditions. This one is for KRABBE disease, and the columns show the states already screening, those with RUSP alignment policies in place, and those with laws in place to screen for it. But it also shows the states that are screening for Pompe and MPS 1 already. Why does this matter? KRABBE can easily be multiplexed, which means screened at the same time as those two conditions, saving states time and money. They like to hear that you can save them money. Arranging the data in this way helps me develop strategy without feeling overwhelmed. Because not everyone loves spreadsheets, we've been making that data more accessible through our state report card project on LDNBS social media. Each week, we highlight a different state with 5 key pieces of information: the number of conditions screened, which leukodystrophies are included, if any, if they are RUSP aligned, how conditions are added, and how many births per year on average. We also share MLD and KRABBE family stories if we have them for that state, and we're always looking for more. And when I have the energy, I try to create videos and reels to share to help educate about newborn screening. You are more than welcome to share these educational resources from our social media channels on your own social media channels to help educate your families as well. LDNBS has also partnered with Orchard Therapeutics on the MLD Story Project, and our goal is to create a fact sheet for every state that includes a family story, facts about MLD and newborn screening, as well as facts about that specific state's newborn screening program. These can be used by advocates in any way they please. We also feature them on our website, and they are available for download. So far, we have 18 states represented. If this is something that could be useful for you, consider asking your industry partners for funding assistance. And finally, we have a YouTube channel, which is probably where you are watching this. This is an area I wish we had more time for, but I am proud of the content we've been able to provide so far. We spoke with Newborn Screening Advisory Board members. We did a boot camp in conjunction with the Every Life Foundation about newborn screening, and we spoke with 2 newborn screening mothers about their experiences and what went well and what did not go well. LDNBS is continually developing resources to make your advocacy journey a little easier. You can access our resources at ldnbs.org. In addition, these organizations have tremendous resources that you may find useful. Thank you so much for listening and for taking the time to learn about newborn screening today. Newborn screening saves lives, and it's critical for so many of our conditions. I have spent the last 8 years becoming as much of an expert, quote unquote, in newborn screening as I can so that you don't have to. There are few things I love talking about more than newborn screening, and I'm always willing to help because it's going to take all of us to save as many babies as possible through newborn screening. We all have our gifts and abilities to share, and this just happens to be mine. I can't wait to see what we can accomplish together. Please email me at lesa@ldnbs.org if you have any questions. And if I don't know the answer, I probably know where to find it, and I will do that for you. Thank you.